A high myope with or mature cataract presented for a cataract surgery. A conjunctiva tenon's combined flap is raised in the upper temporal quadrant. A 6 mm groove is made in the sclera away from the limbus. A tunnel of length about 2.5 mm created encompassing the sclera, the whole of limbus, and the adjacent cornea. It's done under topical anesthesia. Proparacaine topical drops is used to anesthetize the surface. A small nick is made at the anterior end of the tunnel and an air bubble followed by trypan blue is injected into the anterior chamber. The capsule gets instantaneously stained if there is air in the anterior chamber in front of the capsule. It's aspirated with irrigation aspiration. A small rhexis is created. The entry of the cystotome is not through the tunnel, but I have perforated the floor of the tunnel at the limbus so that the tunnel end, anterior end of the tunnel remains closed and the visco remains inside the anterior chamber. So that way the AC does not shallow during the rhexis procedure. The same cystotome is used to disturb certain amount of cortex and epinucleus under the capsular rim. 1% lignocaine is used to flood the anterior chamber so that it anesthetizes the iris, and some amount percolates into the posterior chamber too. But direct injection into posterior chamber is avoided lest it can go through the zonules and cause a positive pressure during the surgery. The nucleus and epinucleus and cortex are rotated in the capsular bag, and more of aspiration than irrigation is done to remove the cortex as much as it's possible, and some amount of the epinucleus, as you can see there. The rhexis is enlarged by the technique which I showed. A fresh entry is made in the intact capsule, and that is drawn in the line of the proposed rhexis. And to initiate the rhexis, it's always easy to start away from the rhexis margin so that you get a nice entry point. It ran to the periphery. I make no attempts to pull the capsule at all because it could run off into the posterior capsule. So a nick is made and the rhexis is completed. Nucleus is prolapsed into the anterior chamber, rotated. It's a hard nucleus, so it needs to be bisected with a cystotome. I'm continuously injecting a viscoelastic, and a groove is made in the front of the nucleus with a cannula. It's bisected using few scratches made by the cystotome itself. Cystotome is continuously injecting HPMC into the anterior chamber to separate the endothelium away from the lenticular movements. Now again I'm injecting visco in front of the nucleus so that it doesn't touch the endothelium. Usually endothelium is quite nice and bright and transparent with a transparent cornea on the day one. You can see the white reflex because of high myopia. There's some amount of scarring of the anterior capsule, but the entire cortex is aspirated. A right cannula is used to aspirate the subincisional cortex, followed by a left J-shaped cannula of the Simcoe, which is irrigation and aspiration type, and it's of a 23 gauge cannula. Some amount of polishing is done to remove the cortical debris as well as some amount of lens epithelial cells. Viscoelastic in the anterior chamber. You come to the area of the capsular CCC runoff at the end of it so that it will not be surprised with the extension into the posterior capsule. Will not normally happen if we have not pulled the capsule to begin with in that area where it ran off. Lens is implanted, and that's the end of the surgery. Thank you.